I don't see many corporate, I'll say, chains having the same kind of umbrella where this chain of ASCs has its own team of IPs to come in and handle this. A lot of times that's for, the administrator to work out within their clinical, along with their DONs. Usually those are the two people that I see the most is the administrator and the DON, and they kind of will give me the overview of this is what we need from you.
Clock in, scrub up, and join us behind the red line, where infection stops and information starts. You're listening to a special combined season of First Case and Transmission Control podcasts, bringing perioperative practice and infection prevention together to tackle one of healthcare's most persistent challenges, surgical site infections. Each episode will connect you with frontline staff, perioperative leaders, infection preventionists, and healthcare innovators sharing real-world strategies, stories, and solutions that are changing the way patients receive surgical care. From the back table to the boardroom, from wheels in to wheels out, and from surveillance data to safer practice, we're breaking down silos and strengthening the systems that protect surgical patients. Welcome to Silo-Free Surgery.
Hello and welcome back to another episode on this special season of Combined Transmission Control and First Case. I'm joined by my co-host, Lindsay Joyce. Lindsay, how are you today?
I'm doing great, Garrett. How are you?
Good. I'm glad before we started recording, we got to bag on a little bit of baseball. Lindsay's out there in St. Louis. I'm here in Cincinnati, so a little bit of rivalry there, but that's okay. And today we're going to be joined by Carlene Smith, and very exciting because, and Lindsay, I don't know, have you ever heard the term triple unicorn?
I feel like I have, but not in the realm that we're probably going to discuss it today.
Perfect, because I was pretty sure I made it up just for this episode, so I'm glad it's a new term. And that is somebody who has the OR background, the sterile processing background, and the infection prevention background. And with this season being so much around silos, we're very excited to talk to Carlene about infection prevention and surgical site reduction in the ambulatory surgery center world.
Brought to you from the studios of Healthcare HQ, let's get into it. This is Transmission Control.
So, Carlene, welcome to the podcast.
Garrett, Lindsay, thank you guys so much for having me on. I'm very excited to be here.
Welcome.
So, Carlene, for the audience members who don't know you or aren't familiar with your work, tell us a little bit about yourself and your career journey to where you are now.
My career journey definitely wasn't linear. Before I was in healthcare at all, I actually spent 14 years as an early childhood educator for the Department of Defense. It was when that base actually closed that I had the opportunity to reinvent myself. And in doing so, I wound up in sterile processing. And that was my introduction into the healthcare world. As I was traveling along that path, I realized very quickly that there's so much more to it than I thought. So I constantly, was always looking for the next thing, which eventually led me to CHL. After I achieved my CHL and I was working more closely with the OR, I realized that they were two entities working so closely, but just didn't really truly have the understanding of what each was doing. Both just amazing professions, both struggling with their own everyday world that was centering around what they needed in that moment, but didn't have the ability to kind of communicate to one another what that meant in terms of how we're, working through the everyday workflow. So I went and I became a surgical technologist. So that way I could truly myself be able to understand what was happening and be able to speak on it from true experience and not just from an outsider looking on the inside. And I did that for many years, and then COVID hit. And a friend of mine had called me because she said, "Hey, I think you'd be a really good fit for this. We have an infection preventionist we need for long-term care, and I just think you'd be really good at it." And me at that time was like, well, there's a need for it. You know what I mean? I have a certain level of understanding, so why not? Why not roll up my sleeves and get involved? So I did. And I spent about a year in long-term care doing IP when I realized how much I missed the stringency of the OR. So back to the OR environment I went, and here I've been ever since, continued on, got my CIC, got my CAPE certification, because they're kind of, I spent so much time in ASCs that it just made sense for me to get my CAPE certification and be able to help people kind of work through what it means to have an infection prevention program in an ASC. Here we are.
That is awesome. And for those that aren't familiar or who haven't heard, that's the CAPE certification. What is that specifically?
Certified Ambulatory Infection Prevention.
So, Carlene, because the CAPE certification is not one that we hear about all the time. So what is the CAPE certification and what does that help equip you to do?
The CAPE certification is Certified Ambulatory Infection Prevention. So it's very focused, ultimately very practical way of applying infection prevention to the ASC environment, which is where, my IP experience. So, it allows me to be able to better support an ASC in terms of what it means to build an infection prevention program.
Nice. And I'm glad you brought that up because it's not one that we've heard about before. Now, you mentioned getting kind of pulled into the ambulatory surgery environment. That's, I think, our first guest from this season that's been specifically in an ASC. And we're going to dive into that throughout this episode on how IP and SSI surveillance differs a little bit in the ASC. But I want to cue this episode up by starting it with exactly what you said at the beginning, which is we are one connected system. So the OR, SPD, infection prevention, we can all work in silos if that's how we choose to go about it. But one of the big themes, and Lindsay, I'm sure you've seen this too, on this season, even so far, is breaking down those silos to get a better outcome for the patient.
Yeah, which has to be done. We can't be working in 3 different entities because then we're all going to be working in 3 different mindsets, and that your main mindset needs to be patient focused first.
Mm-hmm. That's 100% true. And Carlene, what do you think that happens? What, in your experience, what's the root cause behind those silos getting developed?
The silos getting developed, usually I find that most of the time when I explain my background to people that are familiar with, our medical environment, they are usually confused that I'm not a nurse. Is usually the first. And I know I'm not the only one. Like I said, I know that, like, I've spoken to other people who come from even public health backgrounds that find that a bit of a challenge for them when they're trying to enter that very clinical environment. In terms of, for me, it's a little bit different because everything I do is actually clinical. So, you know what I mean? I'm able to see things through different lenses that I really feel can contribute to the greater whole if given the opportunity.
Yeah, that's a really good point because when we think of healthcare, it is very much RN centered and RN forward, which is great, but it's also one thing you realize there's so many other roles and dynamics in the hospital that are outside of being a registered nurse. I think we've all had that experience where they ask, "Oh, are you the infection prevention nurse?" And you kind of got to explain, "No, my background is not in nursing." And then, Lindsay, I want to pick your brain on that too, because sometimes we can go the other way with it by saying a wide range of backgrounds is so significant that we lose a little bit of the importance of nursing in healthcare, in infection prevention. I don't know if you've seen that in your practice or come across that mentality of like, there's not a need to have nursing in infection prevention.
I think yes, absolutely. I have seen that before. I think when you think the infection prevention nurses, I think sometimes there's that mentality that they're the ones going to maybe the floor and is talking with just the nursing staff, your support systems, your support staff or whatever. But then there's the non-nursing infection control and they're coming up and just nitpicking, well, you need to wipe this down. You need to do this. You need to do that. And you need to do that. And it's just yes, I understand I need to clean my instruments or I need to wipe the table down with a certain type of wipe, but also I'm, I have to get this room turned over. I have to, see the next patient. I have my other nursing priorities that then sometimes there is that divide between the two. Like we know infection prevention obviously is very important and crucial in surgery, but we also will, from the nursing mind, we will always, whatever the patient's need or the patient assessment, that's going to supersede anything that we have at that moment.
Yeah, I'm glad you brought that up because it's both correct, both from different perspectives. So, Carlene, how have you seen, especially with your unique background, bridging those gaps, breaking down those silos, being kind of a bridge between those different departments?
For me, it's just an understanding. I have to say, I hold nurses in such a very high respect. I've seen them in so many, like in an OR, my circulator is everything. You know what I mean? My circulator holds the room together. My circulator is watching. They're the eyes and the ears of everything that's happening in there. You know what I mean? So what a tremendous amount of respect I have for that. And that's definitely a lot that's placed on their shoulders in that moment. If you, maybe I don't see that I compromised my glove, but they see it. You know what I mean? So it's just saying, hey, change your glove. And, that's just enormous. As far as understanding, it allows me to see it from a different perspective for them. The same thing in long-term care. You know what I mean? I would go in, you guys I can't inject. So I'm not able to, actually give the vaccinations. But I understand everything that goes into that prior and how much work you're putting in, and like just coming at it with that respect and being able to say, that's great because from my end, I can hold up this, I can put the card together, I can get it together, I can keep the paperwork together. You know what I mean? And you're keeping me together. It's like, it's a teamwork thing. You know what I mean? Same thing in the OR. You know what I mean? I'm here and, I'm relying on you to do those things so that when something is broken or, within the system itself or something that we could be doing better, you bring that to my attention, I can do something to help alleviate the situation and alleviate that burden, that everyday, task that might feel too heavy in that moment because, just like Lindsay said, you have all of these priorities coming at you at once. You know what I mean? And depending on where you stand in the whole big picture, your priorities are different. So really, I feel like everybody's just screaming for their priority to be heard in that moment.
Yeah. I mean, that's true. And nobody's one priority is wrong or incorrect because all of them go back to the patient. And that's, I think, a big frame shift healthcare wide is saying you're not wrong for prioritizing this because we need everybody's little perspective. I think the challenge is then what order we go in and then how we follow up on it.
And that's how nurses get taught in school and we will see this on our NCLEX, our national licensure exam, is all four answers are the correct answers.
Yeah.
But you have to figure out which one is the most correct of those four answers.
That's so interesting to bring up because, infection prevention, it is such a rigid thing. Everything is best practice. It doesn't mean things are absolute. But we're always looking for, this is the one thing that you need to do and then the next thing that you need to do. And I feel like nurses are sometimes better at adapting to the situation in the moment because that's how the training goes. So going to, Carlene, your experience in the ambulatory surgery center, in kind of this theme of challenging misconceptions, there's some perspectives we see where it's like, hey, it's the Wild West. They've got a ton of patients. It's rapid fire. You're in and you're out. And then another that says gaps or limitations in ambulatory surgery. They're very resource constrained. So I want to get your perspective and experience on what are some of those things that makes an ASC different than an acute care setting from the IP side.
I would definitely say resource restraint. There is a lot of times where, ASCs don't generally have a dedicated IP. They have somebody with an educational background in IP. You know what I mean? It's not as extensive as a lot of IPs out there that have actually specifically devoted all of their time and attention to what it means for all the smaller nuances. in IP to keep an environment, and a patient safe. That's not necessarily, it's really nobody's fault. You know what I mean? They're out there trying to do the best they can every day too. But like you said, sometimes have, a patient going down and you need the director of nursing to stop in an ASC to go be able to assist with what that means. They can't turn around and make sure that they're paying attention to everybody washing their hands going into the OR. Like, to carve out those spaces where they can actually spend their time just looking at the things that we need to really focus on to keep our entire infection prevention program moving along and keep our SSI rates extremely low to none. They're not afforded that. So, in a hospital setting, you have a team of people. So there's many of you. Sometimes you can round table. Sometimes you can say, hey, I have this to do, but if you could pick this up for me because I'm trying to prioritize, X, Y, and Z over here, you have that availability. In an ASC, you really don't. I happen to be, I was working in an ASC when I became an IP. So it was kind of like a natural transition. Apply for an IP job in an ASC. So it was very easy for me. And already being in there, being a surgical tech and working in, in the OR and working very closely in sterile processing to make sure all of those processes were following all the standards we needed, I was taking on a little bit of an extra level. So ultimately, I wound up wearing many, many hats.
Yeah, and is that typically how it goes where in an ASC you have a director of nursing or somebody who kind of already has a job, then putting on the IP hat as a part-time or a temporary function when it's needed?
Yes. And a lot of times we handle that by bringing in consultants, and the consultant comes in depending on based on the ASC needs. Sometimes there's ASCs that will have you come in quarterly. Sometimes they have you come in biannually. Some have you come in once a year. Some have you come in and handle the annual IP education that's required. So, where I guess they feel like they need the extra support is where they'll bring you in as the consultant to be able to help them, maintain those aspects of their program and keep them, survey ready.
I was just curious if an ASC is associated with a hospital system, like they have, a major hospital system X in a city, and then they have like an ASC offsite, 15, 20 minutes away. Do those hospital IPs ever come to those ASCs?
So there are certain systems, corporate, that will have their own corporate IPs that come in, but they're still generally handled in this, in the same facet. So they're not the everyday. They just come in and they pick up, certain aspects of what it means to keep that program functioning as optimally as possible in those moments. But there's also so many ASCs that don't have that corporate affiliation that are out here. And I say, like most of those, like you said, are hospital affiliations. I don't see many corporate, I'll say, chains having the same kind of umbrella where this chain of ASCs has its own team of IPs to come in and handle this. A lot of times that's for, the administrator to work out within their clinical, like along with their DONs. Usually those are the two people that I see the most is the administrator and the DON, and they kind of will give me the overview of this is what we need from you.
So in that setup, your acute care, your hospital IPs they're almost functioning as in-house consultants, where they're going to the ASC, before rounds or when they're doing an environment of care rounds, maybe a couple times a year, but they're not seeing the day-to-day ins and outs of what's going on there. Do you feel like it would be a benefit to have a requirement or a standard or an expectation that ASCs have a dedicated individual trained and over their IP program?
Oh, quite honestly, it's, what we're doing is preventative, not reactive. So in that sense, I'd say yes, because we want to be ahead of it. We come in behind it and say, okay, well, this is where, this process failed. Let's figure out what we did. Like, one of my least favorite things to do is a root cause analysis, and not because I don't like the work behind the root cause analysis, but because I wish I was ahead of it before I was here doing the root cause analysis. I wish I had foresight to see, oh my goodness, why didn't I, you know what I mean? Why didn't we catch this faster? Or, and it could be the smallest thing that if you're not, constantly engaging with that program, sometimes we're just our attention, like you said, is so deviated in other areas that one quite didn't make it.
Yeah, and with the trend and kind of care migration to the ambulatory surgery center, I mean, there's great outcomes that come with that you come in and you walk out, or maybe not walk, depending on the procedure that you had, but same day instead of an inpatient stay, or you're there overnight. And then even with physician-owned practices where they are becoming very, very popular and very high volume. And it's kind of a black box, or an area that we don't have great visibility on from a practice standpoint. Now, in terms of surveillance, walk us through how your surveillance goes in an ASC when you're looking at cases, when you're looking at surgical site infections. How does surveillance typically run in an ASC?
Looking at the infection itself, again, I feel like there's a little bit of a lag time or a disconnect in what it means for me to get all the components of that root cause, because we don't have things in-house in an ASC. I can't just send this to the lab. You know what I mean? I rely on picking up the phone and calling, and this is where this patient went afterwards, and now I have a conversation with their office, and now I need those records, and those records need to come over, and I need to be able to take, and I got to go back and pull the patient's chart. And you know what I mean? Everything isn't necessarily as streamlined and, as I would like it to be, So I find that part a little bit challenging. And I don't, like I said, I've done way more ASC than I have hospital settings. I understand that to a point, but like I said, the resources there are just so much bigger than what most ASCs have.
All right. So, Carlene, in how ASC surveillance may look a little bit different than the acute care setting, for the reason that you mentioned, lack of resources, systems that aren't really integrated, you're calling around and trying to get records and probably talking to a couple different doctors' offices in the process. Does what you're looking for when doing surveillance change based on the service or the specialty?
It does. Like I was saying, cataracts, which is my biggest specialty of all of them, doesn't look the same as if you were trying to investigate a knee scope. And again, when you look at the criteria of what, meets the criteria for an infection, each one of them actually have, their own criteria for specialty. Cataracts, for example, aren't actually reportable. They become, or I should say they come to the light usually during survey time because they do ask you. Doesn't make them any less relevant. I still held all the same standards as I would if I was investigating, any SSI.
Right.
It just doesn't have reportable criteria. And, if you're, looking at something like an implant is going to have, a whole different dynamic to it. So I definitely say that they are very specific to the unique specialty.
And that makes sense. And Lindsay, I'm curious how it looks from the OR side of things. Are you looking at different early indicators of a surgical site infections when you're working in cardiac compared to other specialties?
I think for some, yes, but I think in general, the OR is kind of looking at it's a, preventative, like we've been talking. We're doing a skin assessment, in the pre-op area, maybe when the patient gets to the OR, we're making sure that they've got the antibiotics in prior to incision. That's part of our timeouts. There are certain, as we said, certain specialties have certain outcomes that they look at, but I think kind of in general, we're looking at the same as many of these others. So
to that point, which I find very interesting, coming from the OR, like you said, they're getting prophylactic antibiotics, which sometimes I find can make that challenging, because if something does show up, it might be harder for us to actually figure out what it is that's causing the issue. You don't always get those good lab reads, which I find very interesting, because another part of our big, scope in IP is antibiotic stewardship. You know what I mean? So you want to work really hard to make sure that you get the best information you can so that hopefully you can refine that in a way where you are mitigating that while you're mitigating everything else.
Our patients also, all of our patients, not just cardiac, the whole kind of part of the pre-op check-in is they all get the nasal swab with betadine as well to start checking for MRSA. And if that comes back positive, then they can start on broad spectrum antibiotic to treat that specific strain immediately.
So it's these early warning systems are hugely important in this, whether it's the testing, the actual patient exam. And Carlene, I'm curious, if something is not formally reportable, but it is a surgical site infection, what is your process? What do you convey to the team? How do you communicate that out so that we're making practice changes, even if we're not reporting it up through NHSN?
I go through everything is exactly the same. I'm process, for, tracking it and doing my root cause analysis and going all the way, from every step from SPD through the OR through, our pre-op PACU, even, eye drops, making sure all of those processes, that we're following them and I'm not finding breaches because it can come from, other things. Unfortunately, sometimes I don't necessarily get the answers I'm looking for. You know what I mean? Like a patient sometimes wants to go home and you tell them we don't want to touch our eye, but sometimes they go home or they're putting in their own eye drops. There could be so many reasons. So I just have to check everything like it's brand new, like we've never done this a day in our life. Right. Let me just kind of work through this whole situation, everyone from beginning to end. And sometimes I can find changes that are, going to be, helpful to mitigating that from happening again in the future, which, you just write your plan of action based on what you find. So everything is exactly the same. And I keep it in my binder. And that's where it lives until somebody says to me, hey, I see your binder. I say, yeah, here you go.
It's all 100%. Yeah. And you bring up a unique thing that's maybe a frustration that IPs have felt. I'm sure it's felt in the OR as well, where you do all of this information collection and there's really no smoking gun, especially with surgical site infections, to say, hey, this happened or this went a different way than we expected it to. So how do you handle that when there's nothing, I don't want to say nothing to be done, but there's really no smoking gun for us to act on?
Back to the basics. I make sure that all of our, standard precautions, we all get a nice just refresher on our standard precautions, and that's, like that. I certainly, you have to do something proactive. Again, proactive is the route I like to take. I don't like to be reactive if I can help it. So we just go back to the basics and we do a nice overview of everything that we're supposed to be doing, because sometimes when we're there and we're just, living that process every day, it just becomes a rote thing. And sometimes you don't even realize, that one little thing could be changed or done better in our daily workflow. So, I like to keep everybody as fresh as possible on all those basics.
Yep. What a great approach. Have you found that it's helpful? You mentioned consultants earlier, and that may be the typical model is to have a consultant come in once a year or round periodically. Do they sometimes see things that maybe we're nose blind to, or that we're just kind of seeing as standard the way we do things?
Yes, and it's actually one of my favorites, no matter which end I've ever stood on, whether it's me going in with the fresh set of eyes or the fresh set of eyes coming on into me. I actually appreciate it because, like I said, I'm doing these things every day and I'm doing them so rotely that it's very easy to your eyes glare a little bit. You don't quite see it the way it needs to be seen. So when somebody comes in from the outside and gives me a perspective and I say, oh, okay, you know what I mean? And especially when they're open to, giving me that little bit of education or their understanding from, their background, it helps me see things, better, and it grows us all the way I see that. I feel like that's just a growth opportunity for all of us.
Yeah, I love that. That's a great point. And I'm curious, Lindsay, have you seen that in your practice in the OR where it's like, that's just how we do things until something happens where we recalibrate a little bit?
It's the old additive. We've always done it this way. So why do we need to change anything. If, don't fix what's broken. But then when things go significantly south, or, you have a very catastrophic event, or, a patient death, even in the OR, that's when things get changed. And sometimes it needs, that needs to get changed before you've reached that point. My team is very good about, I don't want to say calling out, but, friendly reminders.
Yeah.
That, hey, you're getting ready to roll a patient. Yeah, I know you're just touching the blankets, but maybe put on some gloves. Or, we try to very good. All of our sharps when we scrub are always in one place. So everybody, whether they are scrubbing a case or circulant, everybody knows where our sharps are. So it's just sometimes it's about accountability and just like you said, getting back to the basics and trying prevention.
That is the name of the game. And Carlene, I wonder if your friendly reminders are received better because you've been in the weeds. I know that was an experience going down, with my background in sterile processing. You'd go down and be like, hey, I know why you're doing this because I did the same thing as a technician. Let me tell you what I've learned since then. And this is like what the standards say or what the policy says. And it really softens. You feel like that guard goes down a little bit when somebody says like, yeah, I've been in decontam, man. And I know that you don't want to wear your gown the proper way, but you have to because we care about your safety. I don't know if you've seen that as well because you work kind of in the trenches.
No, yes, that resonates. Really, really resonates because, especially in sterile processing, because I'm such an advocate for sterile processing. It really is the foundation of everything. And, I really love to make sure that I'm supporting them in that way because sometimes they really feel unheard and unseen. You know what I mean? And you come in and you're like, no, really, I understand. I get it. And it's exactly like you said, like the tension drops. They don't feel like they're being attacked. I feel like on a daily basis, somebody's always coming, running in and like, well, where is it? Where is it? It's got to be here. I got to have it now. Or, you know what I mean? Well, what do you mean it's going to take that long? Or, how come I don't have time to put the lid on it? What do you mean I got to run it through the hallway with the lid on? Like all those little things. And they're just kind of the recipient of a lot of that tension unintentionally. It's just because, again, we're running around and we've got so many things and we're turning over the room and we have the patients and we have so much going on and so many things that we need to maintain and take accountability for. And I just feel like they're the ones down there at the bottom going, okay. So when I do go in there as an IP and I understand what that means and I'm like, hey, I get it. And you're right. That's exactly what happens. They kind of take that breath and they soften and they're like, okay. And they're just much more open and receptive to hearing my perspectives at that point. And they also like over time, like they know I'm going to advocate for them in that way. That becomes a trust thing. They know. You know what I mean? I am going to advocate for you. I do understand what's happening in here. I do want to make your processes easier. If there's something you need, even as a consultant, like have the conversation with me so that I can bring that to the light, on your behalf. Yeah.
Yeah, that tension piece is a very real reality in the OR. And I think, we all know crap rolls downhill. I think we forget that downhill is at a different spot for everybody in the team. And we may be thinking, oh man, the OR called down to SPD and they were so upset. And then what we don't realize, and you've probably both seen, is the OR's also receiving a lot of crap from uphill that we aren't seeing. And so we kind of, in this silo conversation, we forget that somebody else has already been receiving a lot of, and I always felt grateful that I was not in the room when those tense calls, because I was at least downstairs where I could take an elevator ride to collect my thoughts. But I don't know, in the OR, you guys are in the thick of it when the tension is high.
I've been yelled at numerous times about why don't we have a certain instrument or, we have to delay the case because there's a contaminant.
Yeah.
And, well, why don't we just, you just magically can't sometimes snap your fingers and just make something appear. We're fortunate that we can, but, sometimes it just, there's, like last week we were trying to figure out, well, none of the instruments for like the OR, we were very delayed. Well, it turned out one of the sterilizers went down overnight. So instead of having 2 sterilizers that could take, 6 carts at a time, they were only getting 3 carts at the time. So they were falling behind. But, people were getting upset about that. But it wasn't until their supervisor came up and said, hey, we were down a sterilizer last night. And all of a sudden, as soon as he said that, like that tension cleared. Like, okay, we get it. That's, out of your control. There's nothing you can do. But we're going to make the best of the situation.
Yeah. It's that camaraderie of like, it's not great for everybody today, but at least we're in it together. And I wonder if there's like the volume piece, which ASCs have huge volume a lot of times compared to their in-house counterparts in the hospital. Does the high volume of ASCs, does it make practice better because we're always thinking about our practices when it's a really fine-tuned machine? Do things fall out because we're doing so many cases a day, especially with the IP practices? What's your experience been with that?
I feel like that can go either way, to be honest with you. You know what I mean? It's definitely, you become very proficient in what that means. Mm-hmm. But again, sometimes that level of proficiency leads to complacency unintentionally. And when that happens is where I find that we see breakdowns. So to have that person that's responsible and have that mindful eye kind of always in the background, just trying to make sure that we can actually have somebody paying attention to both moving parts at the same time, I find that to be very beneficial. Yeah. So in an ASC, in an ideal world, I would love to see them have somebody who can dedicate more time, or at least, like you said, it's not very, it's not a standard amount. As long as you have somebody coming in there and doing it, I would love to see it be something that is a little bit more, consistent across the board for all of us. Like, okay, we need somebody in here, once a month to go through our stuff, or, whatever the case may be, but something that's just a little bit more consistent for everybody, including, I find that helpful because it takes some of that, extra weight off of the shoulders of the nurse, who it's usually, like I said, a nurse who's functioning in a nursing role, right? Those are both really heavy things to hold at the same time, especially in an ASC environment that's moving at the speed of light, like we just said. So I think it's to everybody's benefit to take some of that off of the shoulders of that everyday person and allow them the room to breathe a little bit in the other spaces that could use their attention.
Yeah. And that may be the kind of key for efficiency and compliance, to not be enemies of each other, is you have to actually staff it, and you have to make sure that your leadership team is not risking efficiency for the sake of compliance, which is always the patient safety option, or risking compliance for the sake of efficiency. And if you just don't have enough resources, enough people, that almost becomes a trade-off. Now, Carlene, as we bring this episode home, what is one key differentiator, one thing that if you could have a room full of SPD, a room full of OR, and a room full of IP, what's something you'd want them to understand about one another's practice and work and impact?
That SPD and the OR and IPs are actually one patient safety system. That would be the biggest one. You know what I mean? That's really what, the bottom line to me is. You know what I mean? Working as a team, having a little bit of grace and understanding from everybody's perspective. You know what I mean? Understanding that we're all out here with the same common goal. That would be the one thing that I would love everybody to understand. And for me, I feel, fortunate in that, because I've kind of been in all of these different facets, I can speak the different languages, so to speak, so that they can actually hear one another.
I love that. What an excellent takeaway for everybody.
That's a great way to wrap up the segment, I think.
Yeah. Well, Carlene, we want to thank you for joining us and sharing your expertise, and very unique, especially on the ASC part. This is a great conversation to continue. And thank you, Lindsay, for joining us today.
Happy to be back.
Yeah, absolutely. Thanks, everybody.
That was a great discussion that we just had there with Carlene. So I have to be honest. I have zero experience with an ASC. I have worked in a hospital setting OR my entire career. I know what an AC is. I know what they do. You kind of get the idea of how they operate. They're fast turnovers, fast cases, in and out, kind of outpatient. I know that some ASCs around the country are starting to do, 23-hour observations for totals or spines or whatnot. But I have to say that was a great perspective to learn how infection control and IP works in ASC area for someone who has no experience working in an ASC.
Yeah, I couldn't agree more. In the ASC, it's almost like peripheral. If, like you mentioned in the episode, if you're part of a large hospital system and you've got some ASCs that you maybe go visit a couple times, but I learned a ton on what the day-to-day work for an IP looks like in an ASC. I think this will be a really important conversation to continue. We'll have to have some additional ASC specialists come in because the care volume is growing there. People go in and that is the wave of the future will be physician-owned, hospital-owned ASC, but you're in and out. So very curious to continue this conversation. We want to thank our audience from both First Case and Transmission Control for joining us today. Make sure to like, subscribe, follow, share, tag somebody that works in an ASC. And remember, infection stops where information starts.
Thanks for tuning in to the Transmission Control Podcast, where infection stops because information starts. If you enjoyed this episode, let us know. Connect with us on LinkedIn, Facebook, or wherever you get your podcasts. Don't forget to leave a 5-star rating and share this episode with your team. Until next time, stay informed, stay vigilant, and keep transmission under control.